advise people against the use of enclomiphene purely from a standpoint of we don't know everything about what this is going to do long term. In my clinics, we have a safe work with cream. In Australia, we work with cream and injections. In Europe, we primarily work with cream because it's logistically much easier, but it's important to have both. That they were was that the advantage of DHT and its two metabolites are extremely important neurosteroids. They're extremely important neurosteroids for both.
Oh, man. All right. All right. Welcome back, ladies and gentlemen. Dr. Michael Moeller here, doing my best to bring you more health, wealth, and wisdom. Today, I'm joined by Dave Lee. And it's funny, we just rambled for 15 minutes, and I didn't hit the record. So, noob over here. But, hey, if you're new here, hit the subscribe, sit around. I think a lot of people here are probably already familiar with Dave. He's a big name in the human hormone, men's health hormone optimization space. I first saw him over on the TRT and hormone optimization channel. He did a really great breakdown on DHEA and pregnenolone, which we were just chatting about. So we'll rewind here a little bit. Hopefully we don't repeat ourselves. But Dave and I have been talking back and forth over on social media for a while. And so I reached out to him. I said, Dave, man, let's sit down. Let's chat a little bit about some of these fun things that guys are really trying to figure out in the hormone optimization space. And Dave just brought out a recent book, TRT 101. So I said, Dave, just jump on the live. Well, we're not going live today, but jump on the stream and let's chat a little bit about the book and whatnot. So apologies again, Dave, for hitting on the record, but glad you're here, man.
It's ironic because when we actually started the call, I couldn't get my audio working, and I said I was technically not too good, and it looks like it goes both ways. So look, thank you so much for having me. And as I said before we were recording, but I'll give it a quick run through again. So my name is Dave Lee. I am a health coach originally from Perth, Western Australia. I currently live in a small country that a lot of people don't know where it is. It's called Lithuania. It's technically not Eastern Europe. I'd call it Eastern Europe, but if I call it Eastern Europe, people here get pissed. It's north of Poland, and it's the southernmost Baltic state, so nice and cold. And I have been working in the men's health and hormone optimization space for the best part of 5 years. When I was younger, I never thought I would be working in science. I did my undergrad in digital marketing. I was in a touring band as a musician for a number of years. And everything kind of went south in my life when one day I woke up with debilitating vertigo to the point that I couldn't stand. And this persisted for a number of years. And I was told that it would let up after a few weeks and, compensation would occur. And then after a few years, when it eventually got diagnosed as damage to the vestibular nerve in the right inner ear, I was told that, hey, we found what the problem is and it's incurable. And that was a very difficult process in my life. And I would like to say that I just immediately fought back and pushed through it, but there was definitely a very painful period of defeat that I kind of brush over there. But eventually I did get back on my feet. I went back to university and I learned science. I did a postgraduate diploma in science, which allowed me to transition into a master's in neuropsychiatry, which I very quickly dropped out of because I thought we'd learn how to heal the brain, which that is apparently not what neuropsychiatry is. And my education in science and my interest in how to heal the nerves in the body led to hormones, led to peptides, and led to a holistic health strategy, which I deployed all together as a kind of a Hail Mary to see if I could put my life back together. Fortunately, I was able to do that. And then ever since then, everything else in life, except for helping guys going through their health challenges, has felt superfluous. It's all felt meaningless except for this. So I've been doing this now all day, every day, literally. It drives my wife insane, for the last 5 years. And in the process, as my business has kind of grown and my interest has grown, which I've been very, very blessed with, I have to be able to help more people. I've written a few books, which are very affordable and available. I've made a few videos on YouTube, which some people have really enjoyed and gotten a lot of information from. And now I've opened a couple of clinics, one in Eastern Europe and one in Australia, and I've got a partnership with one in the US as well. And it's all going really well, and it's made a huge difference. So I'm very, very proud of that.
Gordy, yeah, man, you're using those tough situations to turn your life around and help out other people. It's funny, in the naturopathic medical school, it's a very common theme. I had interstitial cystitis, 6 rounds of antibiotics, urologist after urologist, cystoscopies, no help. And then, looked into the natural stuff and it kind of went away. I was like, oh, maybe this quackery alternative holistic medicine actually has something to it versus, yeah, here's your pill. Good luck. See you later. So, it's one of those bittersweet moments. I'm glad that happened to you, Dave. Otherwise, maybe you wouldn't be here today. And that lesson of resiliency, right? I'm sure that's something you work with all your guys. It's like, these can be blessings if you use them the right way.
That's exactly it. If at the time someone had told me that one day I'd be grateful for it when I was going through it, I probably would have punched him in the face. But yeah. I honestly say it now that it was by far the best thing that happened to me, because it gave me the rite of passage that I didn't have when I was younger, and it forged me into someone who I respect, and it's forged me into someone who's been able to build a life that I probably didn't have the capacity to build before. And going through something like that is incredibly difficult, but when you come out the other side, it makes life a hell of a lot easier in contrast, and you learn a lot. And I think that gives character, that gives you traits that other people also respect and admire, and it allows you to build something that creates a life that's worth living. And if it wasn't for a number of things, I mean, you brought up God earlier, if it wasn't for a belief in a higher power as well, and understanding the importance of not calling it quits when things get difficult, I probably also wouldn't have pushed through either.
Nice. Glory to God. And I've heard the term, I like, post-traumatic growth syndrome, right? There's stress there, but it changes you ultimately. And like you said, now you're helping out all these other guys. And it's funny because then that's where your meaning actually comes from. It's like the struggle. And then here you are, like, and you're there, right? You've been where they're at. I think that's one of the big differences between modern medicine. And I have lots of respect for all kinds of healthcare practitioners. But when you sit down with someone, like, I had my testosterone checked at 23, natural bodybuilder, GNC, doing all the things right. And I'm coming in low 400s, free in 50s. And I was like, well, this doesn't make a whole lot of sense. So, that drove me to basically where we're at today, where you're at. I'd love for you to chat about your book, and then to give everyone a heads up today, I'm really excited to chat with Dave about most of the TRT plus, the thing on the side, the HCG, the Enclomiphene. Dave did had a really good conversation with Dr. Kyle Gillette on DHT, hair loss, inhibiting it. So, these are the areas similar to when you did your DHEA pregnenolone video. And I think I looked at it today. It was 5 years ago. You got 60,000 views on that. These are just areas a lot of people, oh, hey, your test is low. Here you go. 200 mgs a week. Good luck. And you had that experience. I've had the experience. It can work very least optimally, but you got to get in the trenches. Things get messed up. And then you have to go to the research and listen to other professionals. I told Dave before this, like, I hope we kind of disagree on some things because I want to learn. I didn't get this far saying I know everything. I got this far being like, wow, what I was told was completely wrong. So what do I do now? And hopefully you have guys like Dave, and like I gave a shout out to the TRT and Hormone Optimization channel. They do good work over there. Unfortunately, you have to self-advocate nowadays too. So if you're not, go subscribe to Dave's channel. If you're not over there, check out his book and stuff. But Dave, if you want to tell us a little bit about the book, and two, you were chatting about DHEA before I messed up the recording. I'd love to hear you chat a little more about that.
Yeah, so the books came about because I'd reached a bottleneck in terms of more people wanted to work with me than I physically had the time to do, which is a great problem to have. So I wanted to put as much knowledge into pages as I could, and I didn't want to rewrite, Jay Campbell's book or anyone else's book who'd come before me, because that had already been done. So I grew up in the 90s playing Nintendo 64 and Super Nintendo. And yeah, fantastic. Jay's book is phenomenal. If anyone hasn't checked out that's kind of like the prerequisite to my book. But I grew up playing these video games that came with these instruction manuals. And I felt like TRT should come with an instruction manual rather than a side effect disclaimer kind of package inside.
Yeah,
so I wrote the instruction manual that I think should come with it. I formatted it like an instruction manual. I mean, I didn't format it. I had a fantastic graphic designer format it, but I basically wrote the instruction manual on how to do TRT, and it was how to do TRT my way. So basically I said, I want to put all my intellectual property in here so that people who can't afford to get to see a good practitioner, maybe they're in a country that doesn't have it available, or, you know, I wanted to put everything in there so that even a doctor or a nurse practitioner could pick it up and copy and paste my protocol and do it right in their clinic. Because my mission has been for as many men as possible in as many countries as possible to get access to proper hormone replacement therapy. So putting that information in an easy to follow guide book for as cheap as possible, about 19, 20 US dollars. That was something that I really wanted to tick a box for. Honestly, I also just wanted to make a product that I could sell with an e-commerce platform so that I could set that system up on my website. I didn't really think the book would take off, but it sold a few thousand copies, and
Wow.
that blows
awesome.
my mind.
Yeah.
So about a year later, I followed it up with a book called Beyond TRT, which took me a lot longer to write, which I call it the myth-busting book, and it goes through pregnenolone, DHEA, thyroid, estrogen, fertility, HCG, all the stuff that people maybe disagree on, or there's a very large amount of noise in the space online about these topics, and everyone's giving conflicting information. And I wanted to write a guide that you could just pick up and go through as a layman and be like, okay, this is what's going on. I also made a YouTube lecture version of that. If people want a free version, you can jump on YouTube and there's me kind of talking through it. And it's led to, I like things in threes. So I've also written TRT 102, which people who haven't done science won't understand the nod to the fact that that's like a university term for a second semester science unit. But that's all my philosophy on masculinity. So it's everything.
Oh, cool.
Everything about how testosterone impacts behavior, and how low testosterone and high testosterone impacts who we are and how we act and how the brain works. And I think if guys have all three of those books in their hand, they should be able to avoid all the pitfalls and have all the questions answered. And if I can give all that information to as many people as possible, I'm happy. So
Amen.
You want to kick off with DHEA?
Yeah, it's funny when you're talking about these books and stuff. Like, I can remember when I first had my patients come in, I used to do a slideshow. And it's funny because I think you were talking about your DHEA being, it's 5 years old already. My first slideshow, I'll be honest, guys. I'll be honest. I had aromatase inhibitors on there. I'm like, if you have gyno, da-da-da. And then it was funny because, again, you look at half-life of an anastrozole, and it's like, well, wait a minute. Testosterone has a 10-day half-life. Anastrozole is like 30 hours. I'm doing this, and your testosterone, your estrogen. And so actually, I'd be interested. That's kind of one of the first things came to my mind. Where have you been with estrogen as an idea? Do you measure it? Aromatase inhibitors, is there ever a time? Are they toxic? They kill you? Or are they, you got to keep your E2 in a range? Or what's been kind of your experience with that?
So for the first year, or maybe even 2 years of treatment, anastrozole, 1/4 milligram twice a week. I did the HCG for a few weeks, but I previously had a varicocele that was embolized, which when I go on TRT without the HCG, it's all good. But when the HCG came back, it flared that up. So I just kind of binned that immediately. But it also made me feel like an emotional, erratic girl as soon as I took HCG. I remember I walked into the gym and I felt intimidated by like 16-year-olds. And I was like, what the hell is going on here? It had a very strong impact on my psyche almost immediately. It was a very strange response. So I immediately binned it. I've revisited it a few times. But in terms of the estrogen stuff, it was interesting because the first time I took that aromatase inhibitor, I was like, this is the best thing I've ever taken in my life. Because my mental chatter, which at the time was a very anxious, very low self-esteem, very self-critical voice inside my head, it just went dead silent. It was like I'd immediately I thought I'd become stoic. I think realistically I'd become pseudo brain dead. But I got this, I got this sense of just clarity, not clarity, but the silence and peace. And I was like, this must have been the missing puzzle. So for the first 2 years, I was adamant that you have to control estrogen, and that when people like Dr. Neil Rouzier came out, Dr. Keith Nichols started talking about never using estrogen inhibitors, I was like, I'm the outlier. I'm the 1%. Like this, I'm the exception. And eventually over time, I remember sitting in this, at the time I just finished up rehab for my brain injury. I was working a few days a week for a not-for-profit, doing a very entry-level minimum wage digital marketing role. And I was in this meeting and I was presenting this website thing that was very, very beneath me. It was very easy. And I just couldn't get my words out. My inner monologue was so silent that I couldn't even think. And my joints were clicking and popping every time I got up and sat down. And I'm sitting there and I'm like, there has to be something wrong here. There has to be something wrong. So being stubborn, I started to break the anastrozole up into like crumbs, being like, I'm just going to take a little bit. And then I swapped to Aromacin. I got Aromacin compounded at like 1 milligram a day. I was like, there has to be something here that works for me. And then when I looked at Neil Rousier's lecture and I really listened to it properly, not from a contesting point of view, but from a point of view that I wanted to listen, and then I listened to Keith's commentary on it as well, I realized that I was wrong. And that's when I swapped to, at the time, doing daily injections for TRT, and everything got better very, very quickly. So I, like you, like to be proven wrong. I mean, the scientific method is that if you have an idea, you have to ridicule it from every angle, and it has to still hold up. Otherwise, it's not true. That's what science is supposed to be. So my point of view didn't hold up. And once I came out the other side of that, I realized that I was wrong. But I also realized that a lot of the reasons why people need estrogen blockers, or they think they need estrogen blockers, they don't need them, but they think they need them, and it solves one problem and creates two more, is what Jay Campbell was talking about at the time, which is that the problem that men are having is that they've got too much systemic inflammation, and a lot of it is driven by insulin resistance. So I focused on getting my body fat down. I wasn't drinking much alcohol at the time, but I was using a bit of cannabis recreationally as well, quite frequently. So I cut that out and did more cardio, cleaned up my diet as much as possible, started to really focus on living more of like what Jay would call like an insulin controlled lifestyle. And things got drastically better very, very quickly.
Yep. And I went down the same rule. I think I told you on the recording that I didn't record. In school, I was taught, right, 1 ml, 200 mgs a week, test sip. You do 250 IUs, HCG twice a week. And at that point, I was taught 1 milligram of anastrozole. And I was lucky enough that I went to an A4M in like 2015. And there was enough people there that kind of like were pushing back on those ideas. But then when I got out and I started practicing on guys, again, I think to myself, I'm like, guys would tell me, hey, I feel good for 2 days or not. And then I up and down. And I was like, man, I got to like tear this apart. So then I went, I increased the injection frequency. And this is when Jay's and the TRT round table started becoming popular. So again, glory to God for that. Those guys, rest in peace, Jim Meehan and Keith Nichols and all those guys, like that was awesome because you're like me, probably bodybuilding.com. You're in the forums. Like I'm trying to get reps. Like when guys are telling me, I want numbers. I need to understand how this works. And so, yeah, first thing I started doing was dividing up the doses, which seemed to help. And then I took guys off HCG, which we'll chat about that because it is just a crapshoot. And then eventually I started pulling everyone off and I lowered the anastrozole doses and I got to the point where I was doing 0.125. I was getting it compounded. And I told guys, take it when it's needed. Because to me, what I was thinking, I'm like, okay, your cypionate's going up and then you're plugging this anastrozole and that's dropping you 60%. And then if testosterone and estrogen are both working on androgen receptors, I'm still a belief kind of in the ratio thing. I know there are people who don't even like measuring estrogen. But the other issue is most guys that come to you and they've at least heard something, right? I had a new patient yesterday. It's funny because he's a younger guy. We went with Enclomiphene, which we'll chat about that too. But his personal trainer like TRT pilled him. Where I was like telling him, and I tell every guy, I'm like, dude, TRT and Enclomiphene, they're not the same thing. You're young, okay. I'm gonna meet a patient where they're at kind of guy. And I'm like, okay, maybe if they get on the bike, they'll want to get on TRT later. But then, his personal trainer's like, yeah. And he's like 21. Oh, you got to be on an anastrozole. And it's hard because then they already have that preconceived notion, right, Dave? They come to you and they go, hey, I'm going to start TRT. I need my anastrozole. I need my HCG. So it's funny kind of untraining them. But then at this point, you're just like, do you measure estrogen, estradiol, E1, E2? Or you're like, you know what? Don't worry about it unless you have symptoms, or what's kind of your take?
I was very heavily influenced by Chris Kresser. Chris Kresser, his book Unconventional Medicine, when I read it, it made a huge amount of sense to me, which kind of birthed this concept of being a health coach. And he had this saying, which is, test, not guess. And that has been a really important thing for me. I mean, in Australia, the panels that we use, it's testosterone, SHBG, free testosterone, estradiol. So I've seen just as many estradiol tests as I have testosterone tests, just by default. I mean, I do work with a small amount of guys in the US, but I always test it. I like to have more information. I like to have more data. And I think the idea that just because we're not going to use an aromatase inhibitor, it doesn't mean that the estrogen number shouldn't be checked. So I just like to check it. I mean, if we can check it, I'm going to check it. So I've seen a lot of estrogen numbers over the years. I wish everyone in the world used the same units so that it would be an easier conversation to have.
Yeah.
One of the challenges with working with guys all over the world is there's a lot more units than people realize that people will use in Europe. So Europe is a mess. But I'm going to talk about the reference range a lot today because we can just, talk about relative to where the reference range is. And what I have found as a ballpark, there's kind of, room up and down. But if your testosterone level is elevated X% above the reference range, your estradiol is probably going to be elevated about X% above the reference range as well, give or take.
Yeah.
So if someone, like when we get guys who come in who are like morbidly obese, drinking a bunch of alcohol, they're pre-diabetic, they're not taking anything to control insulin, they'll have testosterone levels at the bottom of the reference range and estrogen at double the top of the range. That's a problemo. But what I have found is that the estrogen number doesn't perfectly correlate with estrogenic symptoms, but it does to a degree. So I think it is worth checking it. The counter argument is that, well, estrogen is a paracrine hormone, so the level that we're getting in the serum is not accurate. But even Dr. John Chrysler, rest in peace, he used to say that the serum estradiol is a proxy. So it's not to be taken completely literally, like black letter number, but it's still a mark in the sand. So I like to measure it from that approach. But we also can't measure the activity of the androgen and estrogen receptors in the body. I think that's not ideal, but it doesn't mean that the serum estradiol number is completely redundant. It just means that it should be taken with a grain of salt, but I don't like throwing the baby out with the bathwater. I don't think that's a good idea. So I always measure it. Absolutely.
Yeah. And I kind of do the same thing. In the old days, I was able to hold the labs away. Like let's say I have a guy and he comes in and I'll talk total. I know free is more important, but people know total. I like talking about total just because the numbers are easier, right? So, and to make the math easy, let's say he has a 500 milligram per deciliter total, 25 picograms per milliliter estradiol, right? And I'll tell him, I'm like, look, man, if we're going to get you up to 1,000, I'm not going to be surprised if your estradiol goes from 25 to 50. So just so you know, next time we measure your stuff, and I want to ask them symptoms first. Do you have any symptoms? And usually gynecomastia is going to be the only, my opinion, kind of really tail sign. Moodiness. My joke is like, you see a dead bunny on the side of the road and you start crying, or you put on that old George Strait song, you start crying. Like, okay, there's something up with your mood. Whether it's your estrogen or not, we need to figure it out. So I've always and it was funny, after doing this hundreds of times, I just looked at it. Okay, this is probably what's going to happen. And then some guys get symptoms and some don't. I have some guys, I can be at 70 to 80, no issues at all. I'm fine. No nipple sensitivity. And I don't want to mess with it. Kind of like you're saying, when I start guys on TRT, I like doing just testosterone. I don't want to use anything else. Even supplements, honestly, a lot of times, DHT, even pregnenolone. TRT, do this for 6 to 8 weeks. Then we can decide on pulling another lever. Because if we pull another lever, you come back and you tell me X, Y, and Z. And I think that's one of the big things when you want to talk about gyno. It was probably you're throwing a guy on 200 mg of test a week. You're putting him on HCG, which I do think causes gyno. And then you throw him on an anastrozole. No wonder the guy's all wonky and weird and you don't know what's causing what. So I still measure the estradiol, but I really do it just because I have to monitor the symptoms and then figure out, okay, you're feeling better, you're feeling worse. And I tell them, I don't want to mess with it. I don't want to, your testosterone aromatizes on its own. Unless you have symptoms, why would I pull another lever? Especially when these things do, if anyone, go and check out some of those videos that Dave had recommended, like you need estrogen, right? Growth hormone, bones, blood, all that stuff. So, but I get it. That's just baggage, right? And then we have to unpack it. That's half of my visits is unpacking these old ideas. So then what do you think about HCG in accordance with, I personally, I think kind of the idea, you're taking HCG, if it's hitting the Leydig cells, which I know you did a video, I'm excited to ask you about mechanism of action. I think if it's endogenously produced, I do think you get more aromatization. You do get more 5-alpha reductase activation. Because I've seen like a guy on HCG versus a guy on testosterone, way more side effects on HCG, right? Gyno, acne, sexually way more sensitive, moods all over the place. So what's kind of your opinion of HCG? Do you use it at all? Do you think it's worth in the fertility or?
HCG is a really interesting topic. And I think that, I would like to think that we're going to learn more about HCG in men in the coming years if someone wants to fund some more research into it. I don't know if they will, but I'm not particularly optimistic with it. So there's a lot of misconceptions about HCG, and I think the term that gets parroted a lot is that HCG is a mimetic of luteinizing hormone. And mimic means to do the same. So if something agonizes the same receptor but produces a different physiological response, it's not a mimetic, it's an agonist. So an example I often use is that LSD, like acid, the psychedelic, produces the psychedelic effect via the serotonin receptor. So that's like saying that acid is a mimetic of an SSRI. No, it's not. If you take one or the other, you're going to have a very different day. So this term is a massive misconception. And if HCG was a mimetic of luteinizing hormone, it wouldn't cause side effects. So HCG is fundamentally different from luteinizing hormone. And if it wasn't, then I mean, the real question is, why would a pregnant woman make HCG if it does the same thing as luteinizing hormone? They just make more luteinizing hormone. So for the guys listening who don't know, HCG is extracted from a pregnant woman's urine. And then you might be sitting there being like, well, why on earth would I want to inject that into my body on TRT? And I'd be asking the same question. So the idea with HCG is that if you take HCG, because it stimulates the Leydig cells in the testicles, you can keep your testicles active. And I don't think anyone other than cyclists want the small testicles that come with TRT. It's not ideal. I mean, it's not a deal breaker, but I don't think anyone wants smaller nuts.
It's not fun.
It's not fun. It's not ideal, but it's also not a deal breaker. So we have this really tricky scenario, and this is what I talk about in the Beyond TRT lecture. And this is my objective standpoint, which is that, is it better to go on TRT without HCG and leave not just the Leydig cells in the testes, but all throughout the central nervous system and the brain, leaving them dormant, which is not ideal? Or is it better to activate them with something that is not supposed to be in the male body? It's also not supposed to be in the female body long term. And we don't know a single thing that this thing is going to do in the short term, long term in men, outside of the fact that it plumps up your balls. So this is a interesting kind of which one of these is better. And I'm a little bit conservative in a lot of things. And I think that it's best to go with the one that's been studied, because every TRT study that's been done has been done without the concurrent use of HCG. So if there's this myth that if you don't use HCG, you're going to create this deficiency of all these upstream hormones, which simply just doesn't occur in practice. But if that were true, then we'd be going, okay, this is a problem. But we don't see all those problems occur in all the literature on TRT without HCG. So I think there's a lot of myths here. But most importantly, if you give 100 guys on TRT HCG, about 50, 60 of them are going to feel absolutely rotten. And that's the part that I think is really important, is that guys don't feel well when they inject a female pregnancy hormone. And a lot of the time it makes them, it has a feminizing effect. And I'm sitting here being like, well, I don't need a study to tell me why that's happening. That's just kind of common sense. So I think that HCG, people like to talk about being like, well, the reason why HCG is feminizing is because it increases intratesticular aromatization, which you can't block with an AI. And people have all these different theories, which I think is very
I've not heard
interesting.
that one. You can't block it because,
That was the dominant theory in the forums years ago.
Really?
I mean, there's all kinds of crap that people talk about, but
Okay.
I think that HCG is just inherently psychotropic. I think it's both a psychoactive and psychotropic compound. I think that it crosses the blood-brain barrier and has a psychological impact that you can subjectively feel. And I think that some guys are more susceptible or more sensitive to that. And I think that it's, when I look at it, my concern, and I don't want to create fear or anxiety in guys who are taking it, but what could this potentially cause cancer in men long term if they take it for the rest of their lives? We don't know. And that's the thing that scares me.
No, and I've went through this exact thing. I started on it, and then kind of I told you I peeled everything back, went just on TRT. I have most of my guys just on TRT. And then I kind of I had this conversation with them. And to be transparent right now, I am taking 100 IUs on Monday, Wednesday, and Friday. If I go any higher than that, I get acne, I get agitated. If you saw the one Baylor study, they were doing like 1,500 IUs every other day, if I remember. Like these doses, and I'm like, dude, I do 100 to 150. Anything more than that, yeah, I'm cranky, acne, my libido's too high. And it's tricky because, and I don't know, you've kind of heard the idea that you get scar tissue in your testes building up if you haven't stimulated them. You've heard that one, which I've heard varying opinions. Do you have an opinion on that? If the testes aren't being stimulated, people are like, well, then your Leydig cells get scar tissue or they're just not being used. I personally don't really buy it, but I don't know if you have a thought.
My general theory is that if they're not getting a signal from, because when you're in the womb, the testes actually get stimulated by the mother's HCG, and then they don't get stimulated again until you hit puberty. So if you can go through childhood with a decade plus without stimulation, I'd be sitting here being like, well, are they really going to get scar tissue if they're not stimulated for a few years on TRT? I'm like, oh, I think the burden of proof there is on show me some evidence.
Yep. No, and I like that because trust me, that's when I go back and forth on. And again, most of my visits, I'm trying to do this. I'm like, hey, this is what I've seen. This is what we do. Ball's in your court, bud. You know, which I think then kind of brings us over to Enclomiphene being kind of on that same situation. So what's funny about your story with anastrozole, I had the first thing happen on Clomid. So I was 30 years old. I kind of told you in my early 20s, my test was in the 300-400s. I go through naturopathic medical school, right? I'm not, it's stressed, but I've done all the supplements, Tonkat, ashwagandha, working out, eating good, did all the stuff. My test would never get much above the 500s. And my free was hardly able to crack 100. So no grams per, it's picograms. No gram per deciliter would be 10, right? Another zero over. And dude, I'm 27, 28, 9%. I was usually almost always under 10% body fat. And I still ate a lot. I'm like, man. And so I started working at this clinic. And to me, when I heard about Clomid, I'm like, this is it. This is the holy grail. This is the thing that is going to boost me so I don't have to worry about fertility. I don't have to worry about shutting myself down. And my first 25 milligrams of Clomid, I went in the gym and I felt like a God, man. I was like, man, I figured it out. My brain was firing, feeling great. 4 days later, I'm sitting in my bathtub, like listening to some, the Carpenters or some 1960s. I'm like, what am I doing with my life? And I'm like, and it takes a while because Clomid has a long half-life. And I was like, dude, screw that shit. Like, not a chance. But there's been other guys to use that, right? And so then we translate, and then I did HCG monotherapy, and then I found about Enclomiphene. Same thing. I'm like, this is the holy grail. Okay, we're just going to use, Enclomiphene just hits the LH, shorter half-life. And I actually felt pretty good on Enclomiphene monotherapy, to be transparent. I don't know if I didn't have TRT, if I would go back on it, but my levels, like I can get well over 1,000. I have guys on 12.5 milligrams daily who are 1,1400. They feel good. They've been on like, and I tell them most roads do lead to TRT. You know, you're going to do this for a year or two. Maybe you feel a little bit better. This is the bicycle. I go, hey, you know, running, bicycle, car. The other thing I wanted to bring up, though, is you're probably familiar in the States. A lot of people use TRT and HCG, and then HCG got switched, right? They switched it from a biologic to a drug, so they couldn't compound it anymore. It became expensive, and a lot of people switched over to ganadorelin, which I never got on board with that. I looked at the research, short half-life. Be interested your 2 cents on that. But then a lot of people switched to using enclomiphene. I've done that. I'm not fertile. If I'm on TRT and enclomiphene, I'm not fertile. Most of my guys that I tried that with, they're not fertile. There are people out there that claim that works. Maybe it's an individual thing. I mean, there's guys on TRT who remain fertile. But the other thing I want to bring up with enclomiphene was I did give enclomiphene to guys and their testes grew, but they weren't fertile. I don't believe the mechanism of action for Clomid or enclomiphene, because the FSH, when I put guys on, their LH will drop, their FSH goes up, but then their testosterone goes up. So I know that's a wad of a question, but I'd love to hear kind of what you think Clomid and enclomiphene, that fertility, that train of thought.
So there was a period, and I think it was about when I mentioned that I think I saw your first podcast, you know, many years before I got into this side of things, back when I was a patient trying things out, where after my anastrozole saga ended, I was like,
yep,
maybe tamoxifen would be a good idea.
Yep.
Because I'm looking at it and I'm like, well, I don't like HCG, but maybe if I can take a little bit of tamoxifen, because enclomiphene was never available in Australia. Being like, okay, well, maybe like 10 milligrams a day of tamoxifen would bring my LH and FSH back online to some degree, but it's not going to be estrogenic like the HCG is. And I also looked at it and I'm like, it's also got some mechanisms where it's a dopamine reuptake inhibitor as well. I'm like, this sounds like the ultimate drug. It's like a stimulant, and and then I was also reading that people were saying that it could also block the xenoestrogens from binding to the receptor as well. And I'm like, this is the miracle drug that I've been needing this whole time. And the first few days I took it, I was the same as you. I was like, wow. I'm like, this is the best thing in the world. And then I went to get some blood tests done after a couple of weeks, and my bilirubin was just jacked. It was like 40, and I was like, oh shit. So I did some research, and I was reading about how tamoxifen and Clomid can cause non-alcoholic fatty liver disease because of its estrogen antagonistic effects in the liver. And I'm like, crap, this is not going to work out well. So I discontinued it. But also, as I started to, before I got that test result back, I was like, I'm not feeling as good as when I first started taking this. There was definitely a bit of a honeymoon to it. And over the years, I've met a number of guys who must have read the same forums as me back in the day, and probably didn't take the advice of their doctor and maybe took the advice of themselves and ended up running tamoxifen for 6 to 12 months, and lo and behold, had quite moderate fatty liver disease when we ran an ultrasound of their livers. And this is one of the problems with SERMs in general, is that they're not just blocking the estrogen receptor in the hypothalamus. They're doing a bunch of other stuff. So when we've got Clomid and tamoxifen, they're acting as estrogen agonists in some tissues and antagonists in other tissues. They're very interesting drugs. And then when we've got enclomiphene, we're just looking at the estrogen antagonistic side of it, the right isomer of it. So we're blocking estrogen in the hypothalamus, which is what's creating that feedback loop in terms of activating the HPTA axis, but we're also antagonizing estrogen receptors in the rest of the brain and in other tissues in the body. So again, in terms of being conservative, and I guess it's just because I haven't done a huge amount of medical training, and I have my general kind of approaches and rules of thumb, is when I'm looking at enclomiphene being like, we don't know the long-term effects of everything this is going to do. Is this going to be the better option compared to the bioidentical testosterone, which we could also use? Which also, I mean, we're looking at pros and cons. I mean, this one could potentially not shut down your natural production. It's kind of like it's an easier thing to get into in terms of, take a pill a few times a week instead of learn how to do injections, stick your muscle, and all this kind of stuff. So I see the appeal. And, ultimately, I think we all want to have our cake and eat it too. We all want to follow the path of least resistance. For me, in terms of someone who, again, I've just got my own kind of approach and rationale and view on things, I really like bioidentical hormones and essential nutrients for optimizing the human vessel. I think that's my kind of, when in doubt, this is the path to go down. So I advise people against the use of enclomiphene purely from a standpoint of, we don't know everything about what this is going to do long term, and we have a safer option that, well, in terms of safety, because we don't have that degree of the unknown that we have with enclomiphene. And my general concern with enclomiphene is particularly maybe increasing the risk of neural degeneration in terms of blocking estrogen receptors systemically in the brain, whereas testosterone should be protective against those things. So I gravitate more towards TRT, and I'm a little bit, I have my biases. I'm aware of my biases. I've chosen my biases. So I tend to gravitate away from pharmaceuticals, including enclomiphene, personally.
Yeah, and to me, one of the more strange thing that I've heard on guys, when you put them on enclomiphene, their testosterone goes up. Cool. But if you're blocking the estrogen receptor in the brain, it's funny because if you remember coming off the anastrozole, I'm like, wow, I feel like passion again. Like I kind of want to tear up a little bit. Lord of the Rings, King Theoden shows up at Pelennor Fields, and I'm like, yes, I want, like you kind of want that, And so one of my main concerns with enclomiphene has been that, and we see that with the lower IGF-1s too, right? And so like, look, dude, you want to take the enclomiphene, I get it. You're young, you're worried about fertility. These are the things. I don't know how this is going to work. We have no long-term studies. And again, I'm kind of what do I want to say? Very much, I give you the resources. I'm a doctor. If you're going to go and do it anyways, stick with me. We're going to do blood tests. You're probably going to, this is what's going to, I tell my patients this. I'm like, look, you're going to do enclomiphene for a little bit. You'll probably feel a little bit better, but 6 months, a year, 2 years, it's going to fade on you, and then you're probably going to get on TRT. And then you're going to be mad and be like, Dr. Moeller, why didn't you push me on the TRT? And I'm like, look, I don't want to push anyone. I'm here to give you data because I had to go through that, right? I had to do Clomid. I had to do an Anastrozole. I had to do that. I did that because the other thing, very rarely you have a guy that goes on TRT and he's like, oh, could I have done this naturally? Could I have used enclomiphene? Could I have used HCG? If it makes you feel better, because I do think about it, it's like, dude, it's a 20, 30, 40, like you may be on this for the rest of your life. And that's one thing. I've been moving guys around from different esters, cream. I don't like pellets. I think we probably agree on that. But you're gonna be on this for a long time. So we got to figure out, what can you do? Kind of like the lifestyle stuff. Like, are you going to pin yourself every day? It's like, I went from twice a week to every day to every other day. Now I'm 3 days a week, and most of my guys are 3 days a week, because it just seems like I can remember 3 days a week. Every other day, I'm like, oh, was it yesterday? Was it the day before? So like you're saying, 90% of it is, how do you get someone to be consistent, and will they do it? You know what I mean? And I don't really like starting guys on cream for 2 reasons. One is they're paying me money, and if they miss up their cream application and they go in for a lab test and like, doc, I just paid you hundreds, why is my testosterone not moved? And I'm like, it's because you probably didn't play the cream, or you forgot the day before or whatever. I'm like, if you stick this needle in you, this stuff is going on your skin, your testosterone levels are going to go up. So I don't know what your guys, would you like starting guys, but I have been using more and more cream. But out of selfishness for me, out of consistency with my patients, I've been using more the injections to start. Have you found you like one method or the other?
I like having both in the toolbox, and this is something that when I'm mentoring clinics or physicians on this, I really like to teach them that we need to be able to do both. Some guys are needle phobic, and some guys just won't do the cream. We get a lot of guys in Australia who work in the mines, so they're like fly in, fly out, shift work, 14-hour days. Like there are protocols that are just not viable for certain people. So I've been very blessed in my career that a whole bunch of people who I've looked up to over the years have, ended up, becoming friends of mine and colleagues of mine. And, it's very humbling to not be a medical doctor and be respected by a bunch of medical doctors in the field. It makes me very proud. And Dr. Keith Nichols has taught me a lot about cream. And he calls me DHEA Dave, and I've started calling him Cream Keith. I haven't called him that to his face yet, but I will.
I'm gonna clip this one and send it over to him on Instagram.
So he's been such an advocate for cream for a long time. He's made a lot of his videos in terms of like, he just makes very educational videos on YouTube, and that inspires me to make very similar content. So I'm very heavily influenced by him, and it's been very interesting over the years. We kind of butted heads over a bunch of topics, which I'm sure we'll talk about soon in terms of pregnenolone and DHEA, and then eventually kind of came together in terms of being like, hey, I was actually wrong about a bunch of this stuff, and we had a really good conversation in terms of finding a really nice middle ground. And but he's taught me a lot about cream, and Neil Rousier has also made some fantastic information about cream as well. And I got very into the idea of cream in terms of really wanting to understand, is the increase in DHT therapeutic, detrimental, significant?
Yep.
And ultimately, as someone who is, I mean, I started this at 25, I'm 32. I've got a lot of years on this ahead of me. I want the best option for myself. And when I moved to Eastern Europe, getting injections here was not as easy as I'd hoped. Getting cream was easy. So I had my hand forced. I had to swap to cream about 2 years ago. And when I swapped to cream, I was very surprised in that I noticed literally no change. Nothing. No change. I got blood work done. Blood was the same. Everything felt the same. I was like, oh, great. Same thing. So in my clinics, we work with cream. In Australia, we work with cream and injections. In Europe, we primarily work with cream because it's logistically much easier, but it's important to have both in the toolbox. The advantage of cream for some guys. So when guys start on TRT, the problem is that a lot of them are not doing very well because they've been hypogonadal for a while, which tends to ruin your metabolism, your mental health. And a lot of the time people have maladaptive coping mechanisms. They feel like crap, so they live like crap to feel better in the short term. Human behavior. So when guys come in and start TRT, I mean, some of them are in really good shape, but it's very rare to have guys who are sub 15% body fat, eating clean, not drinking any alcohol, exercising, getting plenty of sunlight. Those guys, when you start them on injections, no problem. You can do 2 injections a week. I mean, 3 is always better, but 2 injections a week, they'll typically get away with. And they'll come back in 12 weeks. They'll be like, best thing ever, no side effects. That's not the status quo. A lot of the time, the status quo is 25 to 30% body fat, drinking 5 to 10 standard drinks a week, eating, more takeout than they should, not cooking their own meals, maybe not doing enough exercise, not hitting 10,000 steps a day. And when you take a healthy testosterone level of a fit 21-year-old and put it into a 40-year-old with those behaviors, sometimes it doesn't metabolize perfectly. Yeah. And then people will go, well, the solution for that is blocking the aromatase. And that's like saying, well, if the fire engines are coming and you don't like the sound of the fire alarm, we should just get rid of the fire engines. Yeah. Like they're pulling out the fire. So when we are in this situation where men are systemically inflamed, and again, Jay Campbell and Keith have been, big kind of advocates for this for a number of years, is that the testosterone can sometimes not metabolize favorably. And when we look at the outcomes of what happens from systemic inflammation, we get an increase in the production of aromatase because estrogen is anti-inflammatory, like cortisol. They're not bad things. They're just things that also have deleterious side effects in the body. But we also get a reduction in 5-alpha reductase. So we tend to get increase in prolactin, increase in estrogen, increase in reverse T3, reduction in T3, reduction in 5-alpha reductase. This is not an ideal kind of metabolism profile for hormones. So when we come in with a cream that doesn't go through the liver, because the liver is where the ester kind of bottlenecks so that we can have that slow release effect. When the cream goes straight into the bloodstream and has more exposure to 5-alpha reductase along the way, we get a higher expression of 5-alpha reductase and a higher conversion to DHT. And for guys who are in this situation where they would often have these estrogenic side effects when they start treatment, when these guys take the cream, they tend to actually get a really positive response to treatment. And we'll often get guys come back and they'll come into the clinic and we'll make the recommendation and the doctor will say, look, like we believe that cream would actually be a better option for you because you'll get less side effects. And they'll go, oh, I've heard cream doesn't work. I want injections. And, we're compounding the 20% transcranial cream that works. And we go, look, just give it a try. And so we get these guys who come back and they're drinking too much, they're not exercising, they're overweight, and they should be having a bunch of side effects. And they come back and we go, how's your treatment going? They're like, oh, putting the cream on's really annoying. And I'm like, is that the only problem?
Yeah.
And they're like, yeah, it's annoying. And I'm like, bro, we've just made a miracle here. So the cream works really well for the patient population who would have side effects from injections. And one thing that we'll often do is say, look, we want you to start on cream. And then if you get your body fat down and you get your habits in order, if you want to go for injections, you can give them a try. But from a outcome standpoint, we find that the cream is a great option for the guys that would usually be the trouble cases. And that's where I think the cream really shines.
Yeah, that makes a lot of sense. And I'm definitely motivated me to, especially, I get you're saying that metabolically unfit guy. I'm actually pretty fortunate. Like I'm in California and Idaho, and most of my guys, I get a lot of young, healthier guys. Like most of my guys are 25 to 40. They go to their primary care, their test is 400, and they're like, 28, and doc won't treat them. So I've been fortunate in that, but I definitely think that's something worth doing, cream in that more metabolically unfit person. That makes a lot of sense to me. And it was funny. I think it may have even been you and Dr. Keith talking, and I've watched a lot of his videos on the cream because the DHT thing was scary. So I have on injections gotten my T up to not on purpose. And maybe there'll be a couple questions in here, up to 2000. I don't feel much difference if my and this is even with my free. Once my free's over like 15, I'm okay. 20, 25, I'm feeling good. I don't notice a difference if I'm 35 or 40. And I know some people feel better up there. I had that conversation. Risk versus reward. We're watching blood, viscosity, again, other controversial area we may or may not get to. And I think my DHT was like 100 when I had my total test up to 2000. And then on the cream, it did. I'm like at 700 or 800 and my DHT is like 200. And I'm like, all right, I better be pretty confident that this is, and I've heard kind of Keith's like, dude, that's in the blood. Are you having these? And I didn't get any acne, getting back to that HCG thing. Oh, DHT causes acne. I'm like, dude, my DHT is like tripled and I don't have anything on my shoulders. Whereas with a little bit of HCG, I did. So I'm like, But I do agree. I personally prefer doing a shot 3 times a week than I apply the cream twice. I don't know if you guys do it once. You just once a day is easier, but I really like doing 3 clicks in the morning and then I do 2 before the gym. So I don't know if you found, is that something where you guys are at or?
So again, I give all credit to Keith here, is that I think across the board, stability is king. So twice a day cream applications, I think, is objectively better than once a day because you're not getting a roller coaster. Some guys don't like the inconvenience of putting it on twice a day. I like the routine part because I do it when I brush my teeth. And I have that freedom to know that if I do stuff up and forget to put it on in the morning, then I've still got it in my system from the night before. Whereas if you're putting it once a day and then you forget to put it in the morning, you don't, people think they're going to feel a big crash. You don't. Dr. Neil Rousier talks about how testosterone likely agonizes the receptor for longer than the half-life, which makes sense to me. Because, and when I was thinking about it and I was talking about it with a friend, I was like, well, if testosterone didn't have an effect for longer than the half-life, when young, fit, healthy, 21-year-old men go out drinking and partying, as soon as they start drinking alcohol, they get hypogonadism symptoms. They don't. So that to me makes sense. But I like the twice a day application for stability. The thing where I think it runs into issues is if men are sleeping naked with their partners, because then you can have that transference. That's the only downside of it. And my general rule of thumb is that, I think that intimacy and the loving relationship between a man and a woman is really special and really important. So if that's important to you, I don't want to sacrifice that. But, putting on a pair of underwear could solve that problem. But, I think otherwise once a day is totally fine. Is it optimal? No. Is it acceptable? Yes. I kind of put like once a day cream application on the same level as twice a week injections. It's like the minimum that you can get away with and still have it be acceptable. But twice a day is optimal for cream, and 3 times a week, I think, is optimal for injections. I think daily is ideal for injections, but people aren't going to do that long term.
Yeah. And I did it. To me, the juice wasn't worth the like, I didn't notice. I'm like, maybe 2 times a week. And this is, I usually start guys, especially there. I'm like, dude, at least, like, I tell them 2 days a week, bare minimum. Once a week, you're probably, and I have met guys that can do once a week and they tell me they don't crash, then cool. Do you, man? Like, whatever. I think you'd feel better on twice a week. It makes more sense. Just testosterone's effect on the body, insulin sensitivity, muscle, like all those things. Like, why not? But again, I'm very much, half of it's the patient. Like, what are you going to do? What are you not going to do? What can you do with your lifestyle? So I had the same thing with the cream guy. Like, if that's the best you can do, put it on in the morning. That's great. And if you're not crashing, then okay. The other thing, I don't know if you've noticed, and I personally, and I haven't seen this is as much in my patients with Cypionate's long half-life, I think you're probably having a higher average amount depending on where you're dosing. Does that make sense? Like if you're Cypionate, you're only dropping 10 or 20% every day. The cream, I've heard different things on the half-life. I would assume it's also different by ethnicity and absorption. 4 to 6 hours is kind of where I've put. Do you have an opinion on cream half-life, absorption, and that?
When I've looked into the research of it, and again, they're not doing research on scrotal application. They're doing research on like Testosterone and Andro Forte 5 and things like this. But the half-life appears to be 24 hours is what the research shows. Yeah. There's a pretty substantial peak. You know, it's not like it's evenly distributed across 24 hours. And I think that for listeners to understand that there's a really important distinction between like mean residence time versus half-life. A good example is caffeine. If caffeine's got an 8-hour half-life, you're not getting a gradual increase and then at 4 hours it peaks and then it gradually drops off. And that's not how caffeine works. It hits like a ton of bricks after like half an hour. So there's definitely a substantial peak earlier with cream, but they do find that in research with once a day application, there's 50% serum levels at 24 hours. And that's what we found when we do. I mean, I never ideally measure cream at a 24-hour trough. That to me is a useless measurement. But when guys stuff up and get their blood work done that way, I'm like, okay, cool. I mean, we've got an interesting point of data here. And that's about where we see it. It's about half of the peak at 24 hours.
Okay. And then the other thing that when I was first getting into cream, I was thinking about is I usually shower after the gym, right? So I wake up, I do my 3 clicks, and I'm a mid-afternoon workout guy, sometimes 5 or 6 o'clock. So I'm working out 2 or 3 o'clock, which I think I kind of like. I don't know how that's necessarily affecting the absorption. But one thing that I think when I'm on Cypionate versus the cream is my resting heart rate, I think, is lower on the cream. I think the Cypionate is, you know what I'm saying? It's almost like if it's troughing more, like it's somewhat more similar to the natural circadian rhythm. That was always one of my kind of like, well, if Cypionate and all of the injections, right? If the normal circadian rhythm, you know, in a perfect world, you're waking up at 900 to 1100 and you peel off at 600 to 700 every night. It makes sense if testosterone increases sensitivity to dopamine and serotonin, that's stimulating like your heart rate and your sympathetic nervous system. Right. So I don't know, is that something you guys, any experience or thoughts on that, you know, like the application and sympathetic tone?
This is becoming more of a, like, if I have to say that there's like annual trends for stuff, this trend of the circadian rhythm or trying to mimic the circadian rhythm with TRT has become more of a trend in like the last few months. And I think it's a really interesting point of discussion because we do want to mimic natural human physiology as much as possible. The challenge with mimicking the circadian rhythm with TRT, I mean, I think the best way to do it would be with like probably daily propionate injections would probably be the best way to do it mechanistically. Logistically, it's a pain because that stuff's 100 milligram per mil. And, you know, you have to do daily injections. And I mean, I'd rather do daily cream than daily injections. I mean, just from a comfort standpoint. But the challenge with the testosterone spike is that the spike of testosterone starts at about midnight to 2 a.m. So if we really wanted to mimic that natural production, it would be a prop shot probably before you go to bed, which I just don't think is worth the hassle. I think that in a perfect world, we would be able to mimic the daily circadian rhythm of testosterone. When I've looked into it, to me, and maybe I'm just finding stuff that supports my own viewpoint, and I'm aware of that, but I'm not convinced that there are essential biological processes tied to the relatively mild fluctuation in testosterone levels across the 24-hour period. I mean, there is a flux, absolutely, but there's less of a flux in testosterone compared to something like cortisol, for example, or melatonin. So I do wonder if there is a detriment to the, let's say, doing 3 times a week injections of cypionate or twice daily applications of cream. If there is a detriment to that not mimicking the circadian rhythm, I do wonder if there is a detriment there. I just wonder if that's a detriment that is going to net a deleterious outcome overall, or if it would just be like a flaw in testosterone replacement therapy, because I think testosterone replacement therapy is not a perfect treatment. I don't think any medical intervention is perfect. But I think that is something that people should take into consideration, absolutely. And to me, that's why I kind of like the idea of cream, because having a bit more of a peak and trough, but a peak and trough that aromatizes less because we've got more conversion to DHT, I think that maybe that's mechanistically sounding pretty appealing. But I also don't think there's anything wrong with 3 times a week injections of cypionate either. And I think that in the future, one thing that we use a lot in Australia, and when I say we, I mean not my clinic, but like endocrinologists, like as a country, we use Nebido or Reandron, the different names for it, which is these testosterone undecanoate injections, 4 mil at a time in the glute. And the idea is that you can do it. Yeah, you can do 4 shots a year and have stable levels, which you can't. It doesn't work like that, but it sounds good. I think when that goes generic, a weekly shot of undecanoate will probably give the stability of like daily cypionate injections, but a 200 milligram per mil once a week shot of that. And again, that's not going to follow the circadian rhythm at all. It's going to be very flatline, but I think that's going to be a pretty cool innovation. But it would be nice if we could completely mimic the natural production. I just think logistically, it's probably a bit tricky.
Yeah, no, I agree. And it's funny because when I've transitioned over to cream, I often feel best when I still have the cypionate. And so that's come to my mind, right? And decanate, I think it's 14, right? I think cypionate's, I've gotten flack for this. I've seen as little as 7 days. I've seen as high as 10. I'm pretty sure Pfizer says 9.
Yep.
Okay.
It's about
something like that.
Yeah.
So, but the indecanate, that's like, is it 15? It's over 2 weeks, isn't it? Do you know the half-life on it? I think it's like
decanoate, which is like what nandrolone is. I think that's about 2 or 3 weeks. Undecanoate, I think it's more like 3 or 4 weeks.
Because I think they used to use that in the States too. Like you're saying, you do like 2 ml every 2 weeks, like, and then you'd move to, I forget, like, it's protocol they don't use anymore. Yeah, they front load it and then they spread you out. Because what I started playing with the idea of if I could get my hands on that, I use that to keep me around 500 or 600, and then I cream because I felt really good going. But dude, logistically for other people, sorry, I'm being selfish, but I felt really good. I've switched to cream 3 times now, and the honeymoon phase is like the first 2 weeks, and I still feel good on it now. But I'm like, I'm a very sympathetic dominant person though. Like testosterone raises my heart rate slightly. It definitely, like you're saying, mental clarity. I need less caffeine. It definitely just brightens all of those things. And then the other thing I'm wondering, DHT kind of does the same thing. So kind of, and I know we're coming up on the hour, so maybe we can wrap up, on DHT. I think it'd be great to kind of lead with your discussion with Dr. Kyle. I thought was great. It's funny, you and I have chatted. I've seen enough post-finasteride syndrome that I'm like, I just don't want to touch it. And it's like, cool, you got hair, but your dick don't work. But on the statistics, I think it's something like, 90% of guys are fine, 10% have it. And then it's like 1%, like, do you want to roll a 1 in a 10,000 chance of like, and I forget, they had the one gentleman, he had a really good story on the TRT hormone optimization channel. I remember his name. You just talk to these people with post-finasteride syndrome, and I'm like, dude, I don't want any. And I think 0.25 like 3 times just to see. I could feel it instantly. Never again. And I'm a canary in the coal mine. So I was kind of on when you were going in the thing, a lot of the things you said with I definitely resonated with. And I also get, Dr. Kyle's opinion on things too. So I'm interested on your kind of follow up from that conversation, maybe some takeaways and then your opinion on, DHT.
Yeah, so I really like Kyle. I think a lot of people thought it was going to be like a debate. And Kyle and I are friends. And we've been speaking and chatting for many years. So I was a little surprised to find out that Kyle was I guess partial to the use of finasteride. And over the recent months, in terms of seeing more of his content, one of my favorite things about Kyle is that he's probably the person who I like the most, who I disagree with the most on a lot of these subjects, which I really like to professionally agree to disagree on subjects. I think that being in an echo chamber is just a bit self-serving after a while. So Kyle and I are in real complete agreement on a lot of the holistic stuff. And I think that you and him would also be in complete agreement on that as well. We did a whole video on the TRT and hormone optimization channel where we didn't talk about any medications. We talked about, his pillars of health, which is, the idea of basically the holistic stuff is really important in terms of, spiritual beliefs and family values and, nutrition and, stress management and all this kind of stuff. And so when we got to have this discussion on DHT, there was a point in the video, because it was done live, where I realized that it would be a more beneficial and valuable piece of content for everyone if, rather than arguing, I teased out more of his perspective, because he was coming on a channel that was very anti this medication and he had this kind of opposing views. So I more approached it with the idea of curiosity, because I'm very big on this this book that I think everyone should read, How to Win Friends and Influence People, which is one of, I think, the best books ever. Which is that, if you win a debate, you don't win the debate because now they don't like you, so you've actually lost. So I was really interested to hear his perspective and approach, and at the end of the video, it didn't make me want to try that approach myself or for my clients, but it gave a very interesting approach to be like, look, I think there could be more to this. And the thing that I found interesting with Kyle's perspective was that he still noted that he did advise people to be cautious about using it. So he was definitely still having the conversation to be like, this is not a risk-free thing. You do need to be aware that this can have problems. So I think even the fact that if someone's on the pro side of the medication but still recognizes that there are problems, that the medication's got problems. And I think that people should be really aware of that. My general approach to it, and I stand by a lot of the points that I brought up in the video, and Kyle also schooled me on a couple of points I brought up. I brought up a couple of points and he just immediately shut it down, and I was like, shit, you're completely right about that. I was talking about how I was referencing exogenous DHT studies, and he's like, that's not the same as internally 5-alpha reduced DHT in the cell. And I'm sitting there being like, 100%. I was like, okay, done. School. Yep, done. But
good point.
There were also a couple of points where he agreed with me on, and the points that they was that DHT and its two metabolites are extremely important neurosteroids. They're extremely important neurosteroids for both the function and antioxidant protection of the brain tissue itself, but also behavior. So they're very psychoactive. And when it comes to TRT, and this kind of circles back to the aromatase inhibitor conversation, I think that if we had a real open, honest conversation with a young man who was starting TRT, who wanted to take an estrogen blocker, it's because he's wanting to feel more like a man. And guys think that if they block estrogen, it will make them more manly. I'm like, that is a common sense approach. I'm like, I get that. It's not correct, but I get it.
Yep.
So when it comes to what DHT does in terms of how it impacts neurotransmitters, it increases the activity of a neurotransmitter called GABA, which is what things like alcohol and benzodiazepines and things like gabapentin work on, which is that it's relaxing, it's calming, it's what brings things into balance. It's like the brakes on the brain. And it also increases norepinephrine activity, which is kind of like your brain's version of adrenaline. And when we look at what those two things do together, I like to call that like a Jaeger bomb. Like the combination of alcohol and caffeine, right? That's what people have when they go out, when they want to have a bit of social lubrication, a bit of energy, a bit of drive, and not be overstimulated, not be drunk and woozy. That kind of thing, that's what DHT does endogenously. And when we look at what kind of behaviors and values and attitudes and characteristics that's going to help develop over the chronic exposure over time, that's leadership. Leadership is being driven and being cool, calm, and collected under stressful situations. So I believe that DHT is a really important psychological and behavioral molecule for creating the foundation for the behaviors and characteristics of developing masculinity. And I think blocking that to keep your pretty haircut. And like I just did a lecture at Silverback Summit, and I put up photos of when I was in my band. I used to straighten my hair. I had the whole fringy thing. I cried when I went to the barber and he shaved my head. I was devastated. It was at the time, it was one of the worst days of my life. In hindsight, it was not one of the worst days of my life, but at the time it was. I got over it in a few days. But it was really difficult. And I think that it's really difficult to lose your hair in your mid-20s because that's when you haven't really kind of come into like flourishing as a man yet. You're kind of still finding your feet. No one really takes guys in the mid-20s that seriously. And you're losing a main point of physical attraction. That's a very vulnerable, very difficult process to go through because you feel like you're now not going to qualify to the opposite sex. You feel like you're losing a whole bunch of your value. But what's really important for men to understand is that, one, the shoulder to waist ratio is a more important physical attraction cue for men. But most importantly, when it comes to who you are, your value as a man comes from who you are, what you can do, so your skills, and how you show up and how you treat other people. Like that's what gives you value as a man. It's your capacity. So if I'm sitting here being like, do I want to trade my capacity for being able to be a strong, functional leader of a man to keep my pretty little fringe that I can straighten and look all cool with? I'm like, well, this is just the thing I'm using to hide the fact that I'm not this yet. So male pattern baldness sucks, but it's fine. I mean, half of guys have it. You can get through it, suck it up, and it'll be okay. And that to me is the reality of it. If there was a side effect free way to keep your hair, whoever finds that's going to make a good amount of money. But until that happens, the problem is that if it works, it causes side effects. And that's the trade-off. And I just don't think that it's worth it. And it's like you said before, I mean, if your penis doesn't work, that's not worth it. And the big concern I have, and again, this is coming back to the same thing around enclomiphene, is that when guys are saying, oh, well, I'm taking finasteride or I'm taking dutasteride and I'm not having any side effects, I'm going, well, in 10, 20, 30 years, you might find out if you are having some side effects in the background.
And the hard part about side effects when you're dealing with neurochemistry is like, you don't even know. Like how many people I had come to me on an Estradiol, I take them off and they're like, wow, I feel like a cloud of gray has been lifted. It's like, yeah, you didn't even know. Right. So when these guys take, I have that all the time. Well, I'm not having any side effects. Could be, man, but have you come off of it? And especially if they're on TRT and or not, a lot of times they're not even on TRT. I think it's one thing I think Kyle brought that up. Like, well, if you're bringing it up, does it make sense to kind of bring it down a little bit? Like that makes more sense to me than not being like, if you're on TRT and you're blasting and you're getting up to, 2000. Okay. I still don't like that idea because I don't think you can modulate it properly. My opinion, I've seen too much post-finasteride syndrome and it scared me. I worked at in my first year out of school. I worked at an ED clinic. Did I learn a lot, man? It works with my wife, works with my girlfriend, but not my wife. Finasteride, different supplements, the gas station pill stuff, ADHD meds, all these things. And you realize, like you were highlighting, the intrinsic play between neurohormones. Man, I would like to do a whole other podcast with you on that, especially dealing with your your research on the DHT and preneolone. We hardly had time for that today. You and I got to chat a little bit about, I'm a big nootropics. You know, I tell people my first love, this sounds kind of stupid, but pre-workout was like my first thing. Like, wow, I took this, significant difference. You know, your arginine, your caffeine, citrulline. Then it was nootropics in school. Like, wow, this alpha GPC. I took some, piracetam this morning. And then when I got on TRT, I'm like, these are 3 life-changing things. And caffeine is a debatable one. I'd love to talk to you about that. And the other kind of xanthine, the other stimulants, the risk versus reward. Because like with TRT and pre-work, I'm like, if you go to the gym every day and you're taking an extra 100 milligrams, that is going to help you. You know, and I use Sylvester Stallone and Arnold Schwarzenegger. I'm like, these guys are in their 70s. They've been on TRT. You want to look like them or your average 70-year-old? Because you're not getting through this game alive. Like, you have to walk through this life and figure out what things do you want to chance and what things do you not want to chance. And, you know, it's funny because I actually think as healthcare practitioners, my 2 cents is that is ultimately our goal, is when the guy comes in, how do I meet him where he's at? And how do I take all this information and apply it to you versus like, here's the protocol or X, Y, and Z. It's actually really difficult and no one wants to do it. You know what I mean? Everyone's like, hey, here's your pill. You have a headache, here you go. Versus like, all right, we got to go through everything. You know, headaches, good luck. And the other thing that's funny about the field that we're in is like, it works. I had a guy tell me he PR'd his bench, which I don't bench anymore. Other conversation. He's like 48. And I was asking him, hey, how's therapy? He's like, well, you know, I'm up maybe 10 pounds, lost, 5 pounds down of fat. I'm like, dude, you're 48 and you're PRing on your bench. You put on 10 pounds of muscle. No, dude, 20-year-olds are happy when that happens. So it's funny how all of these kind of, what do I want to say? You know, what's the comparisons, the theft of joy or whatever. And sometimes you have to shake people up, you know, when they're using all these different meds. So, side tangent. Now, Dave, I know we're up over 1:15. I know you're getting late over there. Man, there's still a lot of things I'd love to cover. I think we could go for a pretty long time. If you're down, I'd love to do another one, and we can definitely get more into the neurosteroids and a lot of, I think this was kind of a big picture thing. I'm glad I wanted to run some ideas by you. Kind of any closing thoughts or things that we missed today that we need to button up?
I think most of the subjects we covered that we did close on. I think it would be great to talk about nootropics because, as I mentioned before, I mean, most people kind of get into this field from bodybuilding, and they end up here as an aftermath of that. And I ended up here as an aftermath of neuropsychiatry. So I'm much more interested in how the brain works. And I was very interested in comparing, when I was first looking at testosterone, I was comparing it to things like methylphenidate, like Ritalin, like dexamphetamine, SSRI antidepressants, all the different nootropics. And I was looking at the mechanism of action of testosterone neurologically. I'm like, this is how we fix depression. Yeah. Like, this is it.
Bro.
So I think that's a really interesting conversation. And I remember a couple of very pivotal points in my teenage years. One was my first ever Red Bull. That was I remember that when I was about 13, 14 years old. And I was like, what is this? But I also remember, I mean, when I first got into the gym, I was very skinny. I was the last person people would expect to go to the gym. And I just happened to meet one of my friends from school when we graduated the year before, and he'd, blown up enormously. And, I was just kind of, doing some stuff on the elliptical and hitting a couple of machines. And he's like, try this. I'm like, what's this? And I tried it. And it was the original Jacked pre-workout. And it was the first pre-workout I'd ever had. And that got me addicted to the gym. I mean, I didn't realize, I had no idea what was in it, but I just knew that I loved going to the gym. It was the best time of my day. And I mean, afterwards, I realized it was because of the DMAA, and it's a very dopaminergic stimulant. But that formed the habit of me really enjoying the gym. And even once I withdrew the pre-workout and just started having like some milder ones, and I'm still very into pre-workouts, but not the kind of ones that you buy from the GNCs or from the supplement stores. More so, kind of the more kind of healthy ones, I guess, so to speak. But I found that formed a really positive relationship for me with the gym. And that for me was a life-changing event because it made me passionate about health and fitness. And the kind of general overarching point that I think I'll close on today, just stemming from our discussion, is that if people have listened all the way through, like there's a lot of topics and there's a lot of nuance to this. And my message that I really like to drive home, and I've said this on a lot of podcasts, I say it here: if anyone can't afford my ebooks and you'd like them, please email me. I'll send you a copy for free. I'll send you all of them for free because I want people to have them. But it is so important that if you're considering hormone replacement therapy, to make sure that you have someone who, one, is going to listen to you, and two, knows what they're doing, steer the ship. I know that at the moment it's becoming really trendy and really popular for guys to just buy some tests and just self-prescribe themselves TRT, which I think is a hilarious term. Please, please, please don't do that, because I see guys who do that almost every day, and they come into me to fix the damage that they've done. And it's something that you're going to have to pay for at the end of the day anyway, and you might have to pay back even more. Prehab is cheaper than rehab. So anyone listening to this who's considering TRT, please absolutely do it with someone, like Dr. Michael, or like someone, my clinics if you're in Australia, so that we can set you up for success, not have to put the pieces back together down the track. And yeah, in the next podcast, we'll go through all the interesting stuff on pregnenolone and DHEA. I mean, if you're, based on what you said earlier, I think we're probably in alignment with most things on that topic anyways. So I think it'll be a very interesting topic to go through, and hopefully we can unpack some of the more nuanced stuff in this space.
Yeah. Hey man, Dave, absolute pleasure. Please too also give a shout out, website, Instagram, where do you usually send people to follow your stuff?
Yeah, so I'm mainly on Instagram. I don't like social media, but I've had to kind of get on it in the recent years. So I'm Dave Lee on Instagram, or advancedfundamentalhealth.com is where you can find all my books. I do have consultations available on my website, but I am booked out for a while, so it's best to work with one of my recommended providers or one of my clinics. And I'm also on YouTube. I do have my own YouTube channel now, which I've just set up, and I just released a few days ago my TRT masterclass, which is my everything you need to know about TRT lecture. That's on that channel now. And I've also got a bunch of, I think I've got over 100 videos on YouTube. So if you search my name and TRT, I'm kind of scattered across everyone else's YouTube. So you can find me in every corner of the space.
Yeah. Dave, man, I'm super excited for today. It was an absolute pleasure, man. And I look forward to having some more juicy conversations, man.
Thank you for having me.
Yeah. Until next time, everyone, stay vigilant and God bless.